Hi, I'm Dr. Aliabadi. If you struggle with irregular cycles, acne, facial hair, body hair loss, or insulin resistance, you might be dealing with PCOS, or polycystic ovarian syndrome. Having dedicated my life to helping women with PCOS, I understand the challenges in getting an accurate diagnosis and the right care. That's why I created Ovi, a science-backed alternative to prescription medications. Ovi is designed to help you take control of your health with clinically proven, validated ingredients in a simple, once-a-day solution. For too long, women with PCOS have had to choose between lifelong prescriptions or complicated supplement regimens. Ovi offers a better way to help manage your symptoms without the hassle. It's my mission to empower women facing PCOS and other hormonal issues by providing the information and support they need. Reclaim your health once and for all. Go to ovi.com. That's OVII.com and start today.
So I'm very excited. I feel like we do start every podcast by saying this. I'm so excited about this, but we really are so excited.
Look at her.
But, Thais and I, when we started this podcast, we said, if we're going to do this, we're going to be real, because I'm 53 years old and I'm starting a sober journey. And I feel so similar to so many other women my age that all of a sudden wake up and they're all, alcohol has become this constant in their life. And they're not sure if they're an addict. They just don't know if it's a habit. But somehow the alcohol has started running them instead of them running the alcohol. So I actually was talking to Thais about that. And she's like, well, there's the most impressive, incredible woman that you're ever going to meet is Dr. Stacy Cohen. And I want you to talk to her.
Honestly, meeting her was one of the best things that has happened to my medical practice. And I'm not just saying that. As she said, she's on my speed dial. Like, I text her unfortunately, I text her so many times a day, as much as I love her, but I'm constantly referring my patients to her.
So Stacy, what drove you to really focus on women and addiction?
Yeah, it's interesting. Most psychiatrists don't specialize, but we do have some fellowship tracks. And so I'll talk to the addiction piece first. I had some experiences with people in medical school with addiction, and I was flabbergasted by how much the medical system failed to teach us what to do about this. These were colleague doctor med students. And we were at a loss. No one knew what to do. And even the specialists, it felt like, didn't know what to do. And I felt like I was like navigating this solo in a bunch of doctors. And it was clearly a medical issue, but it wasn't talked about. It wasn't really dealt with. This was 15 years ago, maybe 20 years ago. Wow. And so then time went by. I went into surgery, actually. I don't know if you know this. You probably don't know this about me, but I started at University of Chicago as a surgery resident. And then I was a surgeon, and I saw these doctors around me that were not well. And I remember, it's funny, it's almost Halloween. We had went to a Halloween party with all the residents. And the next day we came in and people were dropping like flies because they were hungover. And these are good doctors. I'm not knocking them. It's just the culture, and it's an intense profession. Mm-hmm. And I said to myself, like, this doesn't feel right. And I always had this calling to do something sort of bigger in the mental health world. And, surgeons are heroes, but I felt a little locked into the OR. I felt like my impact wasn't going to be right for me. So I pivoted. I switched to psychiatry. It was pretty depressing and devastating because your first 2 years you're in the psychiatric wards and you're not really able to do much. Insurance kicks them out really quickly. They're locked in. Nobody does well when they're locked in. And then we did a rotation with addicted healthcare professionals. And I was like in my element because I had been trying so hard to get these people help in medical school, but I didn't have the tools. But this was strictly designed for healthcare professionals that had licensure issues. And I was like, wow, if I can help them, they help thousands of people. Right. And they do really well in treatment. So my first sort of lab for working with people with substance use disorder was a really healthy population that does really well. And it created so much hope for me. And I was like, all right, this feels good. So then I came to LA. I did my addiction psychiatry fellowship at UCLA, and I realized there's obviously a need across, the whole spectrum of people. I should backtrack a little bit. My last year of psychiatry, I don't even know that there still is a really true fellowship in women's and maternal mental health, which is wild because I really think that they're almost two fields, treating just mental health and then women's because of our hormone system. We're just totally wired differently, and psychosocial differences as well. But I did my chief year in women's psychiatry. So we did perinatal, before and after pregnancy. We did postpartum, obviously, and then we did postmenopausal. And learning the differences in women is so critical. But honestly, we're just at the very beginning. I mean, in the 19th century, we were thinking that hysteria was linked only to women because of our uterus. We still call it it's a hysterectomy, and it's hysterical. So, and we used to lock women up because they were hysterical for just speaking out against their husbands. I mean, that's where we were not that long ago. So now we are treating mental health, but we still don't have a paradigm. Look at ADHD. There's boys and girls ADHD. It looks, generally speaking, entirely different. It's like a different disease, but we call it the same thing.
Really?
Yeah.
I didn't know that.
Yeah, we don't say ADHD girl. There's no difference. We just we used to say ADD, then we used to say, or we still say inattentive, hyperactive, or combined.
I didn't know it looked different on boys and girls.
Oh, it looks very different. Yeah. I mean, there are some girls that are almost more like a little boy with ADHD, but most of the time, a lot of the times girls go under the radar. They're more in fantasy land, and they're more inattentive. They're not fighting. I mean, we're built differently. Right. We both have hormones, and we both have all the hormones, but we have very different levels of hormones. And so boys are usually fighting or fidgeting or, disruptive. So they're usually targeted earlier by teachers and whatnot and medicated earlier. And girls sometimes, go under the radar till college. And then they really struggle because they don't have executive functioning skills. So that's just a good example of the differences. So in this chief year, I did all the maternal mental health. I actually did a paper about how to treat opiate use disorder in pregnancy. But the truth is, the pregnancies, people are so invested in learning what meds are safe and not safe. I mean, we went through thalidomide, right? So now it's terrifying to use anything in pregnancy. So to have that sort of nuanced profession in a field that's already huge is so much work. And then addiction, as you can imagine, is just a wildly huge profession that's growing exponentially. I think we're in this psychiatric and mental health revolution right now with psychedelics, with the pain work I've been doing. There's so many different areas of growth compared to other parts of medicine. But when it comes to psychiatry, there's so much left to learn. So for me, the chief year was sort of a great foundation because it led me to look at psychiatry in two different lanes, women versus men. And not that there aren't overlap, but then I did addiction. And so everything was through that lens. So for me, getting that sort of chief year in women's health and then being the go-to for people in pregnancy, because everybody's scared to treat a pregnant patient because they're like, I'm afraid that something's going to happen to the baby and they're going to blame me. But these women are desperate for help. So what happens is the OBs are scared or the primary doctor's scared. And so they just either take them off their meds, which doesn't help them, or they just don't know what to do and they're afraid of liabilities to say anything, because we're in a country where you get sued for everything. So for me, having that lens to enter mental health and then addiction through, I think really informed everything and made me look at everything a little bit differently. So I feel so blessed that I happen to have done that chief year because we all were assigned to pick a specialty and it was life-changing.
So can we talk about the differences between men and women and addiction?
Interestingly, most studies are done on men.
Yes, we know this.
We know that.
So much so that I have to go on a bit of a tangent about perimenopausal women and HRT. Most of the trends in America about prescribing HRT, hormonal replacement therapy in menopause, actually have to do with fears and risks due to studying the use of hormones in men, which is wild to me because we're only really using HRT in women for the most part, right?
Right.
I mean, this is not my field of expertise, but I recently went to this talk and my mind was blown and I checked the facts One of the biggest issues is we don't have great data. And another example is medication-assisted treatment. The acronym is MAT, which is sort of the new buzzword in addiction, which is using meds to treat addiction, not just, talk therapy, AA, behavioral therapy groups, et cetera. And which, is new, but in the rest of medicine, like, of course, in diabetes, we're going to use meds plus behavioral changes. But in addiction, that's a new concept. So relatively new concept. It's been, maybe 20 years, but it's still new. And it's only been utilized well in the last, 5 years. So in the medication-assisted treatment sort of medication, so things like naltrexone or Vivitrol or Suboxone, almost all the big studies are done in men. So we use the medications just like any other medication, but women are handling childcare and trying to work now and do both and do everything. And they're not really they don't really have time to go be in a study. I mean, I actually during COVID enrolled myself in the vaccine study for pregnant women because I was pregnant and I did the vaccine because I knew we needed the data.
Right.
So this is a call to everyone to enroll in a study if you can, because we need the data. Right. I mean, we have a big database for pregnant women. So a lot of times it's after the fact, they found out they're pregnant and they've been on an antidepressant or they've been on a medication for addiction. And now we can at least get some retrospective data, but we can't ethically say like you're getting a placebo and you're getting this med and we're testing it in pregnancy. We just can't.
We started this podcast so we can help women at home who don't have access to Dr. Stacy Cohen to at least have an idea of what to do if they're addicted to different types of medications. Can you walk us through first in a non-pregnant woman, and then we can review the same treatments in pregnancy?
Yeah, absolutely. So first of all, the coolest thing about addiction care is there is free worldwide care anytime, anywhere, or virtually. But AA, Alcoholics Anonymous, there's NA, Narcotics Anonymous, there's Overeaters Anonymous. I mean, any addiction you could think of. There's Debtors Anonymous. There's Shopaholics Anonymous. There's, literally anything. Gamblers Anonymous. Gambling is a devastating disease. There are meetings everywhere. And even though I mentioned some of the nuances that might affect women differently than men, there's women's meetings. There's LGBTQ plus meetings. There are meetings for everybody everywhere in Spanish and any language in the world. You can go online. Since COVID, they're everywhere. And not to say that that's for everybody, but the fact that there's worldwide support, that's
free.
That's free, that's led by people who have been through it, survivors of it. I think if you look at any illness, if you go to a support group with other people, you can get really good information, sometimes more so than you can get at a doctor's office. And by the way, if you're not sure if you're an alcoholic, you can go, there's something called an open meeting. So you can go and just see what it's like. And that really helps. People are afraid to go, but honestly, I think it should be part of education. I think everybody should have to go to an AA meeting so that they don't feel afraid to go for the first time when they're terrified about their illness. There's Al-Anon for people whose family have addiction. So needless to say, there's meetings everywhere all the time and they're free. Other resources. So
what happens when, I can talk about that because I did come to see you.
Yeah.
So we had a session and we talked about my history and then my genetics. And, I come from a family of addicts and how I was feeling. And then we did talk about medication because I had tried to quit drinking before. And this time I needed a little more help, I felt like. So that's what happened. And so you just sort of talk to your patients and then it just depends on.
Yeah, I think it's really important to see a doctor that knows and specializes in addiction. That I would say that's number one. The meetings are great because they're everywhere, but what happens is people go to their primary care doctor, and I got to tell you, I don't think we had a week of addiction training in medical school or education. There used to be none. Now I think there's supposed to be a week. I think when I was training 20 years ago, there was 2 days maybe. So to go to a primary care doctor, unfortunately, a good one is a good gatekeeper and gets you to the right place, but you're not really going to get that specialty. So you want a referral to an addiction specialist. And then what the addiction specialist does is they start by psychoeducation. They teach you that this is really a disease. People are still struggling with the idea that addiction is a disease. We actually have a location where addiction lies. It's the limbic system. It's the animalistic part of our brain that's really involved in sort of the caveman stuff like reward, pleasure, survival, sleep, things like that. But that area of the brain is essentially on overdrive and hijacking the rest of the brain. So we know now, thanks to this amazing woman that was studying this at NIH forever called Nora Volkow, we know now that it's a disease, it's localized to this area of the brain, and we actually have medications that can treat that urge and that craving and that drive in any addiction.
What are those medications?
So there's only 3 drugs of abuse that we actually have FDA-approved medications for, and they are alcohol, opiates, and tobacco. And of each of those drugs of abuse, there's 3 medications in each category. So for alcohol, there's 3 medications. The oldest one is called disulfiram, and that's the one that makes you sick.
That's antabuse, right?
Antabuse.
Okay.
So that really works through learning. It's like you get food poisoning from alcohol, so you don't want it anymore. But you have to take it every single day. And to get somebody whose brain is sort of miswiring and not good at executive functioning, like the CEO part of the brain is not working in addiction, to take a medication every day, it's hard. So the newer medications that have been used there's 2. There's a camprosate or Camprol. It does have to be taken 3 times a day, which is a little bit tricky. And then there's the one that's used probably most commonly today, which is naltrexone. And naltrexone actually comes in a monthly injectable, almost like a vaccine, called Vivitrol. It's an underdog med that I'm so passionate about. So Vivitrol both treats alcohol use disorder and opiate use disorder. And we're talking about the opiate epidemic at all times. And people are primarily talking about Suboxone, which is also a great medication. But Vivitrol is actually a non-opiate, opiate blocker. And the way that I don't want to get too technical, but the way that it works is it blocks opiate receptors. And opiate receptors are actually responsible for the endorphin rush that comes from drinking. Because endorphins they work like opiates on opiate receptors. If you think endorphin, morphine, they work on similar receptors. So there's a cascade of events that lead to an endorphin rush when you drink, and especially if you're genetically wired. So basically, if you're at risk to become an alcoholic due to a high ACE score, which is childhood trauma, due to genetics, which is super genetically linked. So if you're already predisposed, and then your brain starts liking alcohol, it's almost like riding a bike. It's like muscle memory. Every time you drink, your brain goes right back there. So this medication stops that like excitatory response.
And it's an injection once a month.
Once a month.
What side effects?
So this is the cool thing. So unlike most psychiatric medications, they're very low. In the opiate study, 2% dropped out because of adverse events in both the placebo and the medication. But when people do have side effects, things like nausea, dizziness, in alcohol users, there's those types of side effects, which you also see in alcohol withdrawal and like we call post-acute withdrawal or PAWS, post-acute withdrawal symptoms. So weeks to months, sometimes people feel nauseous or have low appetite, sometimes things like that. And this can make those a little more prominent, but it's really low, less than 10%, left both placebos, like 7% and 9%. Left the study in the placebo group, alcohol group, and then 9% in the med group. So really low side effects is the bottom line. So that exists, but also the oral naltrexone exists. And there's actually like starting to be a national shortage because it's gone generic and whatever. But bottom line is there's 3 medications, and every medication doesn't work on everyone. You have to figure out what's right for whom. But that's where I think it's very important to involve a doctor because just like depression, you can do therapy and get better for mild to moderate depression sometimes, but oftentimes we need to use a medication and it can totally change, the treatment of depression. And also, so the SAMHSA protocol, that's the national governing body of protocols, recommends medication plus behavioral treatment for all addictions, just like for depression. It's medications plus, not for everybody, but everybody should be offered and educated about medications, and that should be the standard of care.
And you brought up hormones and women and hormones. And obviously that's such a big difference. How do the hormones come into play with addiction and depression and sort of everything?
This is a big one for me. I mean, we talked about sharing our stories. I had horrific postpartum, horrific. And I'm probably one of the most well-connected psychiatrists there are because I have a big group practice and I'm, talking to the thought leaders. I mean, I was hanging out, sipping coffee with Gabor Mate at a conference who was like my idol. So I could really call anyone, and nobody knew what to do. begged a doctor to give me hormones. So now we have a medication called Zurzuvae. This medication just came out in 2023. Before 2023, there was a similar, it's an allopregnenolone
IV
mimicker.
infusion.
Yeah. IV infusion. I had people coming to me saying, we have a postpartum med. And I was all excited about it. And then it turned out you had to go into the hospital and get an IV infusion for many days and be away from your baby right after you had, I mean, it's crazy. So that used to exist, and it was like $60,000 a day, and that's before the hospital fees.
Can you imagine that?
No,
It's wild.
honestly,
I mean, and postpartum is rampant. And
Rampant.
it's dangerous, and it's
Yeah.
important, and it happens to like anyone. I mean, I didn't think I was at risk because 3 months after I had my baby, I was on cloud 9. And then the minute I stopped breastfeeding, I was
just
like, and it was paralyzing and it was terrifying. I ended up like pushing somebody to give me hormones, but now we have Zurzuvae. So it came out in 2023. It's so new that none of the pharmacies knew what it was. No one knew how to order it. No one knew how to get it when I tried to get it recently for a patient, but I did get it eventually. But you can imagine if you're not like me and incredibly stubborn and don't give up, like if you're a doctor seeing hundreds of patients, like you don't have time to fight with the pharmacies, but we did. And it works in 1 to 2 days. And that was what I had to go on all these like Facebook groups and blogs to talk to other doctors. Who's used this? What dose did you use? Because, and I tell the patient this, I said, look, we're like pioneers. We're going through this together because this is new. But like me, this patient had tried different antidepressants. When I was postpartum, I tried 4 or 5 different things. And I just could tell. I was like, this isn't the problem. This is hormonal. And I was right. But there just wasn't medication for it. So now there is, which is great. So back to your question about addiction. I can't tell you how many patients, their mood cycles around their period and their addiction cycles with their period. Or they have endometriosis,
Oh
the
my
great
God, I
masquerader.
love you. Oh my God, she took the words out
I
of
just
my
got on the
mouth.
phone with a guy, but he's a surgeon who one of my patients connected me to. If I have a patient who is like, oh my God, I struggled with it for 15 years and this surgeon took out my endometriosis, which was hiding, and he changed my life and this is his passion. She's like, you got to meet him. I got on the phone with him and he was literally in his full scrubs, you know, the helmet thing. And he came out, he's like, sorry, I'm in surgery. I don't have much time, but I'm so glad to meet you. And he's like, I can't tell you enough about how many of my patients have mental health symptoms and they have
Because of endo.
endometriosis.
Yeah.
And he talked. And then he sent me like 20 texts. And he's like, he sent me these free resources to track your cycles and your moods. And I was like, oh my God, you're an angel. But there aren't that many doctors that can really do all that.
We shared a patient together who used to use opiates in pregnancy, and it was just devastating, and you helped her so much. And
We use Suboxone to get that patient off opiates.
that-
And sometimes we can detox
During
them.
pregnancy.
during
Yeah.
pregnancy, but you know what I was trying to explain to her during pregnancy was that there was a reason for her addiction, because she had endometriosis that was undiagnosed for most of her life. And these patients, because they get dismissed, they have chronic pelvic pain,
So they take opioids for the pain.
and doctors give it to them. I had a patient walk into my office. She was 24 years old a few years ago with a Percocet prescription. And she said, I came here because you always talk about endometriosis. I think that's what I have. But the doctor on the 5th floor just gave me this prescription. It was Percocet. That is why these patients become addicted to these pain medications. So we're partly at fault for not diagnosing these
we're a
women.
big part.
And, you know, she helped this patient with her addiction. I helped her with her pain. And
It takes a village.
it takes a village, but you can't just look at the addiction. You also have to look, why is this person drinking? Why is this person using
Well, so that's
narcotics?
actually a great point. So we just talked about 2 different phases of life for women. And then you have the next phase of life, which is perimenopause and menopause. Are you seeing a lot more women like me come in who don't feel like they're an alcoholic, but they just all of a sudden they wake up one day and they realize that they've had a glass of wine every single night. You know what I mean?
I mean, we used to think that a glass of red wine a day was good for us because of antioxidants and whatnot. And now the recommendation is no alcohol. It's poison. I mean, that's what really the national recommendations are from NIDA, National Institute on Drug Addiction, because it's not healthy. But I will say it's especially not healthy for women. Our incidence of stroke, cancer, dementia, falls, and as you know, we have lower bone density as we age. So then broken hip, and then you get the infection, and then you're in the nursing home. I mean, that's really what happens. People drink they fall, they hurt themselves, or they hit their head, they're much more likely to have a more lasting brain injury if they fall down. If you're a woman, breast cancer risk is higher, liver issues higher, stomach cancer higher, women's cancers, endometrial lining, uterine cancers higher in people who drink. We don't metabolize alcohol as well as men do. We're just not as hardy in that department. We're also more fat-based and we have estrogen and whatnot. And so we just don't handle alcohol as well. And one of my biggest motivators for women is like, it's going to age you.
Yeah.
And
when you wake up and you see that face,
your
after
skin's not going to look
yeah.
as good. It's going to age you. You're going to be dehydrated. You're going to have liver issues. You're going to get liver spots. You're going to have fatty liver. I mean, it's going to age you. And it's true. It's not good for us. And it's a shame. And I tell people, there's a book called Quit Like a Woman.
I've read
I tell people to read it. We're different than men, and we need to treat ourselves differently. And I'm not saying men should drink or it's good for men, but what we can handle is a lot less, and our risks are a lot higher.
When you see, and you've had so many patients walk through your office, the ones that can get sober and the ones that don't, is it the ones that do it are on medicine and therapy, or is it like
I don't believe that anybody can't get sober. I'm very stubborn. I really don't. I will keep trying till the end of time to help somebody. If they want to get sober. If somebody doesn't want to, that's a different story. Sometimes our people are pushed into it by their family or whatnot. But I think of mental health and resiliency and recovery. I think of psychiatry and the mind as a thumbprint, and we all have a different one. And so you really have to look full picture. Sometimes somebody's drinking because their thyroid's off and they're tired and it gives them energy. Other people are anxious and they have too much energy and it brings them down. Other people are drinking to like deal with side effects of some medication. Other people are drinking because they're in a bad marriage. Other people are drinking because they don't have purpose. They really wanted to go back to work and they didn't get a chance to, and now they're lost and it's an escape for them. I mean, people are drinking for all different reasons. So the best thing I can say is like, I have to really listen to my patients and get to know them. There's almost always some sort of trauma. Sometimes it's a little T, sometimes it's a big T. So
I just heard that for the first time today, little T and big T.
Yeah, little T. I mean, big T is like
Sexual
rape, sexual
trauma.
assault, or you're a veteran that went to war, you were in a near-death experience in a car accident, beaten, etc. Little T can be as simple as like, my parents didn't pay attention to me because we had a special needs kid in the house and they told me I didn't need anything and I was neglected. Or I was bullied at school, or we moved a lot because of my dad's job and it created social issues. It can be very subtle. And then they get older and they don't know how to handle emotions. And so anything that feels scary, threatening, or dysregulating, they drink. And to get back to your question about perimenopause, so many of these issues are living in the nervous system, which is so influenced by the hormonal system, parasympathetic, sympathetic, and then female hormones, men's hormones. So, and I work with the trans population as well. So I know a lot about, whether their testosterone's too much or their estrogen's too low, whatever it is. Our nervous system is so much more important than we're giving it credit for. So the example of chronic pain, we were targeting the knee when they had knee pain, but when it's chronic pain, it's actually the nervous system is sending the wrong signals to the brain. When it's acute pain, that's like you put your hand on the stove and your brain's telling you, up, danger, remove it. But chronic pain like endometriosis, knee pain, headaches, back pain, which oftentimes happen in perimenopause, we're given painkillers. And actually, there's something called opioid-induced hyperalgesia. When you use painkillers for too long, they make the pain worse. You get sensitized to them and you actually get more pain because you're on painkillers than you had before.
And you end up using more and more and more.
Yes, and you get tolerance and you get dependence and you get withdrawal. And then you put that on top of postmenopausal or perimenopausal symptoms. It's just a mess. Or PCOS symptoms. It's just a mess. So oftentimes we actually treat with psychological interventions that I say now are like surgical. Like we're working psychologically on the nervous system to create new signals so that when you feel this sensation in your knee or your back or wherever, you actually teach your brain that you're not in danger. And then you don't get all the fear and worry and I'm not going to be able to function tomorrow. I'm not going to be able to work. and you actually let the sensation just come and go. And that's how we treat chronic pain now. It's revolutionary. It's like since 2021, there was a big back pain study where we learned that it actually, pain lived in the nervous system. So I come to the perimenopausal question because the reality is, and this is true about perimenopausal symptoms actually, a lot of them live in the nervous system. So the only universal perimenopausal symptom around the world is vasomotor symptoms, so hot flashes. Mm-hmm. That's the only one. And yet we have mood swings, vaginal dryness, sexual side effects, anxiety, depression. Those are actually very culturally localized. So in cultures like parts of Asia that actually super honor the elders, they actually only have vasomotor symptoms. Isn't that
really?
There's actually not really a word for menopause because in certain cultures, because they actually honor aging so much that the sensations of the vasomotor symptoms don't create this entire nervous system dysfunction. Whereas here in America, there is this emphasis on youth and beauty in women here in America. So all of a sudden, women are in menopause. And the impact of that is it's not about honor. It's about, I'm losing my childbearing years. I'm not going to be hot for the men. I'm going to be aged out of my marketing job. And so our nervous systems actually go into overdrive at just the slightest sensation of a hot flash or night sweats. And those can be really paralyzing and devastating, and they do exist, and those exist worldwide. But interestingly...
But so what do you do with patients that
Great question. Happens? So a lot of times we need to be doing very targeted therapy on the nervous system. So we need to teach the mind to be calm. We need to teach the body to be calm. We need to teach ourselves that we can handle emotional changes. And I'm not saying that all perimenopausal symptoms can be treated with psychotherapies, but sometimes it's trauma related. So EMDR is like one of my favorite go-to trauma treatments that's, studied in Western medicine with really good, profound studies that show it works. We're now using psychedelics, which is super exciting. It really depends on what's going on because it's almost like our minds. I feel like our minds are like an orchestra.
Yeah.
And sometimes it's like one thing is out of tune, or sometimes the whole facility is too cold, or sometimes we need to do like a hormonal thing to shift everything, or sometimes there's just like one neurotransmitter out of whack. I see that as like, okay, the saxophone needs to be tuned or something like that. So in order to get everything to be harmonious, we have to really investigate and figure out what's going on. So there's not really one treatment for perimenopause. It's kind of like, what are your symptoms? How are they affecting your life? What should we be looking at more closely? And for some people, it's as simple as like, I'm having hot flashes, I need hormones. And for other people, it's like they're having a midlife crisis of sorts and they need a reboot of a whole bunch of things and they need to go away somewhere. So it really depends.
So what are you excited about in the future of mental health?
I'm always telling my patients this. I'm like a broken record. I'm using like 10 new meds in the last 2 years than I used to use before that. We used to have 4 categories of psychiatric medications. I'm going to start with medications. So we used to have antidepressants, mood stabilizers, antipsychotics, I guess 5, stimulants, and benzos. And that was it. So if you look at antidepressants, which most people, the majority of people who have mental health issues have anxiety, and then depression is next, and then comes bipolar, schizophrenia, et cetera, addiction. So antidepressants, literally we had one group of medications that all worked in very similar way, a little bit different here and there, but basically on serotonin for the whole blanket picture of anxiety and depression. I mean, that's mind-blowing to me. Now, there's many different ones, and some have a little norepinephrine or this or that, but basically antidepressants were just antidepressants. And trauma was just thrown in there. So for PTSD, which is very different than anxiety or depression, but it's lumped together half the time because there's overlap, we just would use SSRIs, Prozac, Zoloft, Lexapro, et cetera. Psychedelics create a whole new avenue of medications. So we can treat trauma. We could treat it more effectively, more efficiently.
And so when you talk about psychedelics, that includes what?
Yeah, we kind of put ketamine in there, although it's more of a dissociative anesthetic, but we put it in there. Ketamine, MDMA, psilocybin. Now, MDMA and psilocybin are not legal yet. Only ketamine is. If I want to send somebody to a study through one of the formerly known as MAPS programs or whatnot to do psilocybin or MDMA, that's different. But right now, with the laws the way they are, I can really only recommend ketamine, or I can only prescribe ketamine. So we're doing that. We've been at the forefront. So in 2019, when Spravato, the branded form of S-ketamine, which is similar to ketamine, came out, we started using it. And S-ketamine is limiting because it's expensive. It has to be used a certain way in the nose, and it's hard to use in the nose for a million reasons. So ketamine is now more widely used in more progressive medicine for trauma, anxiety, pain, and it's used IV, intramuscularly, oral, nasal, so that it's widespread. My feelings about ketamine is it's one tool, and it should be in the right hands.
Right.
And there are people out there that their entire practice is devoted to ketamine. It's kind of like, to me, one of my concerns, and this is a concern that I have, it's not just ketamine, it's just ketamine's the hot thing right now. It's a concern at large. It's like Adderall. For a kid with severe ADHD, or sometimes adults, Adderall is a game changer, and it gives them a life, and they don't get in car accidents, and they do better in school, and they can function. But for a lot of people, it's like a death sentence. And so there are these sort of private equity run pop-up medical practices now, and they're not sort of decisions made by doctors. Doctors are sort of a pawn at the bottom, maybe a PA or an NP. And their whole business model is to drive the sales of Adderall or ketamine or whatever it is. And I think it's incredibly dangerous. I think ketamine is a scary drug. I'm treating a patient right now who is severely traumatized because her therapist, and this is happening all around, her therapist, who got some training in ketamine-assisted psychotherapy, did a group of patients, put her in that group, and gave her ketamine to heal her trauma. And during that session, all these memories came up, and she didn't know what was true and what wasn't about sexual abuse, etc. And she is now severely traumatized because she did not feel safe in that group of people. She didn't feel safe with that therapist. There wasn't a doctor there. But it is a breakthrough. So I started by saying we only had these tools.
Right.
I am so grateful we have ketamine. Ketamine is indicated for by the FDA, but we use things off label all the time for treatment-resistant depression, and it's a very good option. It's a great option. Some contraindications in schizophrenia, bipolar, but for trauma, for anxiety, for depression, I think it's a great medication, and I think
Used by the right doctor.
yes, I think it could be used more liberally. I think it could be used well, but just like Adderall and benzos, which were the next best thing when they came out, it really needs to be used with caution, because what happens is everyone's excited for something that works. And I'm so excited that we have things that work, because I can't tell you how many of my patients for decades were using the same antidepressants, doing the same talk therapy without results. And I've had patients where it changes their mind so much, so rapidly, and that's great. I think psilocybin and MDMA are even more promising. I think we're limited by just ketamine, but I think they're more promising.
So when do you think we'll have approval to use it?
Well,
Because patients go to different countries.
I know.
They get it illegally.
And that's the other thing. I'd much rather it be in my hands than these other, shamans that aren't shamans.
I feel like some of this
Yeah,
is
I mean, I've
similar.
had patients that are taking ketamine in my office that have had such serious reactions that, we're not sure. And we know what to do. We're equipped, but I know a therapist wouldn't be, because my nurse practitioner, my nurse will call me, and someone's always on site, which is not the case for most places. But in my practice, there's always a doctor there. And we're not sure if they're having a seizure or hyperventilating, or if they need to go to the hospital. We're not sure if they're having a cardiac event, because it's so profound in its ability to lift trauma or kind of basically, our brains have sort of a set mode, a default mode, and this gives it a totally different perspective, and it can be really powerful and really scary and really overwhelming for people. And then there's also, you can get a stroke. Your blood pressure can skyrocket. I mean, there are people in the underground world doing great journeys with MDMA and psilocybin, but there's also people trying to capitalize on this quickly that don't have the experience, that don't have the medical training. But I don't want to talk just negatively. I am so excited about psychedelics. And believe me, I was the first person to sign up when Spravato came out and suddenly it was legal to use ketamine or forms of it. And it was sort of standard of care to be able to try. It's a big deal. And
What
I'm excited.
is psilocybin good for? It's more for anxiety than depression, right?
Yeah,
Or
so ketamine works on NMDA receptors. It's an antagonist. But psilocybin, MDMA, they really sort of go directly to ego, some people would say, or the fear centers. The amygdala, for example, is part of the fear centers of the brain. So our SSRIs don't do that at all, by the way. They sort of mute intensity of feelings and they can uplift. But nothing we've had until now in the psychedelic space, which August, everything got, basically MDMA got negged in August.
Because it was supposed to get approved.
It was
and
supposed to get
everyone
approved.
was so
and
excited.
that was going to sort of I mean, ketamine has started the psychedelic revolution in medicine, and MAPS, the organization that was now bought by a drug company, they did all this great research and they geared up to get it passed by the FDA, and it was disapproved. So
why do you think it was disapproved? Because every psychiatrist I spoke with last year, they were all waiting for August. They're like, in August, we're going to start prescribing.
Oh my God. I told my patient, I was like, we have ketamine now, but like, we're going to have psilocybin soon.
Yeah. So what happened?
For example, we look at weed, right? Pot, marijuana. All of a sudden, it got decriminalized. And then all of a sudden, there were doctors writing scripts for it everywhere. Right. The amount of young people in psychiatric hospitals because of marijuana use with psychosis skyrocketed. I was in residency training when that happened, and I can't tell you how it was devastating. It was so sad, and some of those people never come back from their psychosis.
That's what
it unlocks the schizophrenia. The amount in Colorado, when Colorado was like the first to decriminalize, the amount of ER visits in toddlers that got a hold of candy, the amount of hyperemesis, things like that from vomiting excessively from marijuana. So it's not with that. I'm really excited. I think that mental health is in such an exciting place. And I could talk about this forever because I'm so passionate about it. And
but everything has its pros and its cons.
Yeah.
And everything has its risks.
So I'm excited, but I also don't think everybody needs it.
Right.
I also think it needs to be done in the right time in someone's life. And I'm still educating myself. As you know, we have to do continued medical education. There's a lot to know and a lot to learn. And I know for a fact, like most of the people out there that are distributing these drugs don't have that knowledge. Mm-hmm. And so they feel like, oh, I'm a healer, I know how to do it. But they don't know what to do with someone who's having a seizure. Like they just don't.
A stroke or their blood
anything.
pressure.
But anyway, it's going to help a lot. It's also going to create a lot of problems.
Right. I want to talk to you about two things, actually. One is EMDR.
Yeah.
Can you tell us what it is, how it works? I know sometimes when I call you, you say it's great for trauma. Can you talk to us about it? Because a lot of people don't know what it is.
I don't know what it is.
Yes.
Yeah, it's really good.
Okay. I love EMDR. So the way I describe what we're dealing with trauma, EMDR is a trauma treatment. Mm-hmm. And basically in prolonged trauma, the body thinks it's in danger when it's not. So you're misfiring your danger signals. So you're responding to your husband like they're your abusive dad, but they're not abusive.
Right.
Or you go into a work setting and you're acting like you're being targeted, but maybe that was something from the past. So what happens in memory is, this is my dumbed down version of why EMDR works and what the problem is. When you have a trauma attached to the memory, imagine in your memory bank, or if you're at a library, that the trauma memory got tagged as a trauma memory and it got shelved somewhere else. Mm-hmm. And that somewhere else is the limbic system. Other memories don't exist in the limbic system except trauma memories. Mm. So that memory gets stored in your reptilian brain and your safety system. And now anything that triggers that memory is going to tell your body that you're not safe. And so what EMDR does is, quote unquote, surgically relocates that memory from the limbic system to elsewhere. And how does it do it? It almost seems like a sort of hypnosis, but what you do is you do some sort of bilateral movement. And by the way, when we sleep, REM eye movements, the only thing that moves when we sleep is our eyes. And if we're a man, our penis can move, but we're otherwise paralyzed. In a healthy sleeper, you're paralyzed during REM sleep. And REM is when memories are consolidated. So, and they're sort of placed on the shelves. So what we do is we create an almost sleep-like state. And by the way, we don't know 100% how this works, but this is the best way I can describe it. We create almost a sleep-like REM state by either doing, like, I tried EMDR during COVID. So I did it with somebody on a screen where I followed a ball back and forth. Or you hold sensors in your hand if you're seizure prone, for example. or light sensitive, or you have bilateral ear volume things. So basically, through these bilateral movements, we create sort of a sense of almost hypnosis or sleep so that the therapist can surgically move the memory from the limbic system, the fight or flight safety system, to the normal memory system, so that when things pass us, triggers happen, we don't go into that state, because it's very hard to operate from that state in a normal way and make good decisions and think calmly. So that's what EMDR does.
And how many sessions do you need to do, and what?
Great question. Yeah. So
How successful is it, by
it's
the way?
very successful. Now, psychedelics can be more successful, which is why they're so important to add from an efficiency standpoint. But the big studies that like Vanderkolk, the Body Keeps the Score, that's the name of the trauma book, and the author of that and some other really important trauma experts are all pushing psychedelics because they study them in acute trauma victims and chronic trauma victims, but all of them will tell you that doing the trauma work first will yield the best results, like EMDR first. And having done that trauma work and then doing psychedelics, like you can really integrate the trauma work. Everybody's different. We talk about the thumbprint, and also trauma's different, and also it's a bit operator dependent. It takes a while to get safe with your therapist to do it. So some people that's 2 sessions, sometimes that's 5 sessions. And you have to be stable enough to do it. If you're in an acute sort of state of panic, trauma, depression, like it's not the right time to do EMDR. So it has to be with an EMDR certified therapist. Typically around 8 sessions though, which is pretty
how
quick.
often do you do
Weekly, if you're looking at the 8 sessions, you could do it more often, but it could be a bit dysregulating. So sometimes it trudges things up.
And what percentage of patients respond to that?
Depends on what study you look at. And it depends on the type of trauma, but we're looking at like 60, 70, 80%,
Wow.
which is big for trauma. But by the way, psychedelic can be that much.
Then why not do it with every cancer patient? I mean, I speak for cancer.
Yeah,
because
I'm a
I had
cancer
breast
survivor
cancer.
too.
Did you do EMDR?
I had thyroid cancer 3 times, and I've honestly lived with thyroid cancer for so long, and it's different. I'm not to say that it can't be serious. So it wasn't the same type of trauma for me as cancer can be traumatic, but I do understand cancer trauma to some extent. But I had other trauma that I wanted to look at. So when I did that, I did it around other trauma. But you can really do it for any trauma. And the cool part is you don't have to use your actual trauma. Like some patients are way too severely traumatized that they don't want to revisit it in EMDR. You can do it around being called a name in 2nd grade, which is what I did. I was called a name in 2nd grade, and it kind of stuck with me. I used that example in my EMDR to address my nervous system at large. So you don't actually have to go back to the big trauma, which is so cool. I think it's so cool.
Can I ask you guys both a question?
Yeah.
With addiction, something that's been a lot of people are talking about is with these new GLP-1s, Ozempic, Mounjaro, that a lot of people are saying that they're noticing that for addiction, all kinds of addiction. So you're dealing with food, but that they're saying, I don't want to drink as much. I'm
so glad we have the non-doctor bringing us to a very important point that we both talk about with our patients all the time. I have seen Ozempic be revolutionary. I mean, revolutionary. Low-dose Ozempic for perimenopausal symptoms and the weight gain. This is off-label, of course.
Right.
And also there's a shortage, and there's people who really need it for their diabetes, et cetera, et cetera. I disclaim everything.
No, we're talking medically.
But yes, can really help with some of the weight symptoms, also, and some insulin resistant symptoms and stuff. Also food noise. So I actually just met with an eating disorder clinic, and I said, are you guys using it? And they're like, no, of course not. And I said, I bet you in a couple years you're going to tell me something different, because we have been looking at binge eating for so many years. The best we could do was Vyvanse, a stimulant, which can cause all these other problems, especially in anxious patients, whatnot, bipolar patients, et cetera. So the fact that we have a medication now that can stop what I call with my patients food noise, you know, that food becomes the go-to when you're stressed, when you're overwhelmed, when you want to comfort yourself and you just can't stop. And that's unhealthy. It's not good for you, right? And then a lot of times it's sugar cravings, and that happens in perimenopause. And a lot of times there's belly weight, and that can cause then self-esteem issues, anxiety, this, that, the other thing. Clothes don't fit, but it's bigger than that. It can cause devastating self-esteem consequences, suicidal thoughts, depression, etc. So I've seen a good number of patients do really well with their food noise. But then on top of that, there's some really good data about alcohol use disorder. And I can't tell you how many patients went on it for weight loss, and as a side effect, they're not interested in alcohol.
I don't know if you know this, but I was one of the first doctors who started prescribing this in 2014.
I do know
and
that.
I have seen anxiety gets better, self-esteem gets improves,
Totally.
less skin picking, acne picking, alcohol smoking. I mean,
Totally.
it's been,
Impulsive disorders. And naltrexone sort of similar in that, the Vivitrol medication. We didn't have good medications for these behavioral things, and we totally need them. And it's totally great. Just like psychedelics, I'm so excited that we have this. And yes, I talk about my fears, but really the truth is we're helping so many more people and we have more tools, and that is incredible.
And the only thing I want to add, and I always add this when we talk about eating disorder, a lot of these young girls with eating disorder have an underlying condition called PCOS. I love you for that. I know we've talked about this. And I always say, if you ever go to these centers, if you ever talk to doctors who deal with eating disorder, just know at the root of it could be polycystic ovarian syndrome. And the reason Ozempic is helping those teenagers is it's because it's addressing their insulin resistance, helping their weight, shutting that noise.
And imagine squashing that pattern so much earlier, and they don't have to live a life of decades of pain. It's the same thing with chronic pain that I keep alluding to, but it's like we have these patterns that then we have to shake and try to do behavioral therapy that can take forever, and to keep somebody in it when all these other stressors of finding a job, going to college, all these things are happening at that stage of life.
Right.
And we could squash that. It's huge.
I know you said that you're really excited about this pain therapy. Can you want to talk about that?
Yeah. I know it wasn't on your radar, but it's on mine. The things that, like, Sanjay Gupta talks about this, and I think he's right. Like, we have some really big challenges as people age because we have an aging population. We're living longer, but it's even happening in young people just because of stress. Chronic pain is a massive problem. Headaches, period cramps, knee pain, neck pain. It's just a massive problem. And there are some amazing studies, one of them specifically from 2021 called the Colorado Back Pain Study. I don't know the exact name, but basically they found out that, where they looked at half the people had issues on MRI, and they had half of them didn't have back pain despite issues on MRI, and half of them had back pain despite no issues. But regardless, everybody who had back pain went through 1 month of something called pain reprocessing therapy. And this is just an example of sort of surgically targeted therapies. And 1 month later, 2/3 were pain-free, and that lasted still a year after that. And their functional MRIs were taken during pain, and then a month later and a year later, and the pain was gone in 2/3, and the other third had marked improvements in their pain just from a month of this very targeted type of therapy to treat pain. And it's all talk therapy.
And it's called what?
Pain reprocessing therapy. But then there's other things like polyvagal work. There's different therapies, but my point is that we've been dealing with some sort of very costly, not just from a monetary perspective and a healthcare system perspective, but also time in people's life, which is sort of our most precious commodity, and money, targeting the body when the nervous system, specifically the mind, but the nervous system at large is really the target. And this is why the field of the mind is so important right now, and having new medicines and new tools and new therapies and new breakthroughs is just it's so exciting.
As long as people understand chronic pelvic pain.
You're right. I went to some place to talk about pain, and they thought nothing was actually structural.
So,
I'm like, no, that's not true.
Check and make sure that it's not a medical condition.
Endometriosis.
If you're
is the great
young
masquerader.
and if you are in your reproductive age and you have painful periods or you have chronic pelvic pain, you need to go to an expert endometriosis specialist near you to make sure you don't have endometriosis, because I always say the top cause of pelvic pain in a young girl is endometriosis, yet doctors don't diagnose it. So they do end up in your office with addiction, with pain
And I always tell them to go get their hormones
I'm so proud
checked.
of you.
Yeah, I have, but because I've seen it all. So it's not, that's why it's like never an easy answer. And that's why you have to go to medical school and do all these things to really know what you're doing.
So Stacy, for all the women listening that are thinking about, or think they might be addicted or sober curious, like, can you give us just a few tips for them? Like, what should they do if they're listening and they're like, oh, this is really resonating with me?
Yeah. First of all, don't be afraid to be a trendsetter. If you look in most cool restaurants these days, they have mocktails. I drink them because I don't want to feel like crap the next day, because that's all alcohol really does for me now at this point. Know that women medically, really don't do well with alcohol. So if your driver is that you want your skin to look good and you don't want to age, like, let that be it. But it's actually contraindicated and unsafe. And so I think just some basic psychoeducation on that is important. But if you're struggling, don't be afraid to go online and go to an AA group just for women. You can put a different name. You don't have to put your face up. Once you start to hear other people's stories, you realize you're not alone. And that's very powerful. It's actually powerful for even the chemicals in our brain to know we're not alone and feel like we're not alone. But you can order a mocktail. You can be the trends, and you can say, you know what? Yeah, I read that, I heard on this SheMD that it's going to make my skin wrinkle. Whatever you want. Don't be afraid to be different, because the truth is, I think in the next 5 years, like, a lot less people are going to be drinking. It's going to be like the cigarettes of our time.
Right.
Yeah.
So it's
in fact, it's more healthy.
And I have to add one thing, which I really didn't know this. When I took my daughter to a neurologist, pediatric neurologist at UCLA, the first thing she told me is, thank God her mom only did heroin and meth. The worst thing you can possibly do in pregnancy is alcohol.
I'm so glad
Really?
you said that, because so
Drinking
many people
alcohol.
have their glass of wine
So
still.
drinking alcohol is worse than doing heroin and meth.
I did not know that.
For developmental issues. Yeah, actually, I mean, fetal
Physical
alcohol syndrome
features.
is an actual syndrome. For opiates, it's that we might have to wean them off with morphine. But for alcohol, they will have physical malformations, they'll have developmental, they'll have behavioral issues, they'll have intellectual challenges. And there's a lot of patients that I see now that probably have some variant of fetal, it's a spectrum, but they probably have mild fetal alcohol syndrome, and it's caused lifelong challenges. So yeah, I'm so glad you said that, because there's this myth that, like, oh, you can still drink. No,
a little bit of alcohol, because Europeans do it. I'm like, no alcohol, no alcohol.
Right. I'm so glad you said that.
First of all, thank you so much for everything you've done for my patients, because I never get to thank you. I'm always texting you in a panic mode. 10 p.m., people text me, as you know, and I just divert those text messages to Stacy, and you take the best care of them. You're so knowledgeable. You're so caring. You're so loving. You're so good at what you do. Thank you for taking the time to come here and talk to us about this. I would love to have you again. I mean, we can talk about mental health.
Yeah, we should talk more about mental health. A lot more about that.
Especially
we're going to have to have you come
I
back.
think so, yeah. I should mention my practice, because
Please. Anybody that wants to learn more about you, will you tell her?
I have a team-based approach to what I do, because I by no means think that I know everything or can do anything or should do everything. The Moment Health is my website. It's themomenthealth.com, and we're called The Moment, really as a reminder, because really living in the moment is one of the best ways to have strong mental health. And I actually just opened a sister clinic that's an insurance-based in-network practice.
Great.
That's a teaching clinic. Yeah, that I haven't had time to tell you about, called Seventh Health.
And you take all insurances, or just
most major
private?
Insurances? We're working on a couple more stragglers, but most of the major insurances we take. We're working on a Medi-Cal
and it's a teaching?
It's a teaching clinic. Amazing. Yeah.
And I want to try your EMDR.
Yes.
I know we've talked about it.
We'll get you hooked up.
Me too.
I want to reshelf my breast cancer trauma. Dr. Stacy Cohen, thank you so much for bringing your knowledge and your experience to SheMD. We loved having you.
Thank you for trusting me with your patients, most importantly, and thank you so much for having me here.
Thanks so much for joining us today on SheMD.
If you want to own your own health, a good place to start is by following us on social media at SheMD Podcast, and by subscribing to our show on YouTube or wherever you get your podcasts.
For takeaways from today's episode, visit our website, shemdpodcast.com. We'll see you next time on SheMD. This podcast is for educational and entertainment purposes only. It is not intended as a substitute for a physician's medical advice. You should regularly consult your medical provider in matters relating to your own health. Even though we share our honest beliefs on SheMD, some of the products and services we discuss may involve sponsorships or paid advertising.